Hello, good morning. So today in this class, I will discuss about megaloblastic anemia. So megaloblastic anemia, they are associated with macrocytic blood picture and megaloblastic marrow erythropoiesis. Megaloblastic anemias, they are due to deficiency of vitamin B12 and or folate and includes megaloblastic picture. There are two types of etiology. Number one, there is a nutritional deficiency of vitamin B12 or folate, or there is a combined deficiency, most common in the developing countries. Second type of megaloblastic anemia is, which is because of deficiency of intrinsic factor causing impaired absorption of vitamin B12 called pernicious anemia. This is rare in India but more prevalent in individuals of European descent. The megaloblastic anemia, they are the disorders caused by impaired DNA synthesis and are characterized by a distinctive abnormalities in the hematopoietic precursors in the bone marrow, in which the maturation of nucleus is delayed in comparison to the iron deficiency anemia, in which the maturity of cytoplasm is delayed. So nucleus is maturity is delayed relative to that of the cytoplasm. So since cell division is very slow, but cytoplasmic division progresses normally. So the nucleated red cell precursors tend to be larvae, which early in 1880 termed as megaloblasts. Megaloblasts are both morphologically and functionally abnormal, with the result that the mature red cells form from them and released into the peripheral blood are also abnormal in the shape and size. The most prominent abnormality is macrocytosis. So the underlying defect for the asynchronous maturation of nucleus is defective DNA synthesis due to deficiency of vitamin B12, that is cobalamin, and or folic acid, that is folate. Less common causes are interference with DNA synthesis by congenital or acquired abnormalities of vitamin B12 or folic acid metabolism. So here is the salient features of vitamin B12 and folate metabolism. Vitamin B12 is mainly found in the animal proteins, while the source of folate is green leafy vegetables and meat. Cooking of the food has little effect on vitamin B12, but folate is easily destroyed by cooking. Daily requirement of vitamin B12 is 2 to 4 microgram, while folate daily requirement is 100 to 200 microgram. So daily recommended intake for vitamin B12 is 5 to 30 microgram, and daily requirement of folate is 100 to 500 microgram. Vitamin B12 is absorbed in the ileum, while folate is absorbed in the duodenum and jejunum. For absorption of vitamin B12, intrinsic factor is required, while folate is absorbed by conversion into methyl tetrahydrofolate. So body stores for vitamin B12 is 2 to 3 milligram, which is enough for 2 to 4 years, while folate body stores are only 10 to 12 milligram, which is enough for 4 months. What is biochemical basis of megaloblastic anemia? There is a homocysteine methionine reaction in which homocysteine in the presence of B12 is converted into the methionine, while plasma folate is methyl tetrahydrofolate. This by reduction converted into DUMP, and which is required for DNA synthesis. So block in the folate deficiency lead to defective DNA synthesis, while block due to drug with normal use folate level is from tetrahydrofolate to dihydrofolate. So what is the biochemical basis of megaloblastic anemia? The basic biochemical abnormality common to both vitamin B12 and folate deficiency is a block in the pathway of DNA synthesis, and that there is an interrelationship between B12 and folate metabolism in methylation reaction of homocysteine to methionine. Folate as a coenzyme methylene tetrahydrofolate is required for transfer of one carbon moiety, that is methyl and formyl, to form building blocks in DNA synthesis. These one carbon moieties are derived from serine or forminoglutamic acid, that is FIGLU. Etiologically, we can classify vitamin into two groups. Vitamin B12 deficiency, it is either because of inadequate dietary intake, that is in strict vegetarians or breastfeed infants. Second is cause of vitamin B12 deficiency is malabsorption. In the malabsorption, there are some gastric causes, for example, pernicious anemia, gastrectomy, or congenital absence of intrinsic factor. This leads to the malabsorption of vitamin B12. Intestinal causes are that if there is a tropical stool, ileal resection, Crohn's disease, intestinal blind loop syndrome, or fist form infestation, then there is a defective absorption of vitamin B12. Why folate deficiency is because of inadequate dietary intake, especially in case of alcoholics, teenagers, infant, old age, or because of poverty, there is an inadequate dietary intake. This is also because of malabsorption folate deficiency, especially in tropical stool, celiac disease, partial gastrectomy, jejunal resection, or Crohn's disease. There may be an excessive demand For example, in physiological pregnancy, lactation in infancy, or pathological in malignancy or increased hematopoiesis, chronic exfoliative skin disorders, tuberculosis, and rheumatoid arthritis. These conditions lead to the excessive demand, and this is responsible for folate deficiency. Excessive urinary folate loss, that is, in active liver disease or congenital heart failure. Other than this, there could be a impaired metabolism, that means inhibitors of dehydrofolate reductase, such as methotrexate and pyrimethamine or alcohol. They all leads to the deficiency of folate, or there may be a congenital enzyme deficiency. Other uncommon causes may be de-Guglielmo syndrome, congenital dyserythropoietic anemia, or refractory megaloblastic anemia. What are the clinical features in a case of megaloblastic anemia? Deficiency of vitamin B12 and folate may cause clinical manifestations which may be present either singly, where means either there may be deficiency of isolated vitamin B12 or folic acid, or there may be a combined deficiency of vitamin B12 and folic acid both in varying severity. What happens in the clinical feature? Number one, there is anemia. Anemia is macrocytic megaloblastic anemia. It is the important cardinal feature of deficiency of vitamin B12 and of folate. The onset of anemia is usually gradual, and it is gradually progressive only. There may be a glossitis. Typically, the patient who had megaloblastic anemia have smooth, beefy, red tongue. Then there are neurological manifestations. Vitamin B12 deficiency, particularly in the patients of pernicious anemia, is associated with significant neurological manifestations, which are in the form of subacute combined degeneration of the spinal cord and peripheral neuropathy, while folate deficiency may occasionally develop neuropathy only. The underlying pathological process consists of demyelination of the peripheral nerves, the spinal cord, and the cerebrum. Signs and symptoms include numbness, paresthesia, weakness, ataxia, poor finger coordination, and diminished reflexes. Beside the macrocytic anemia, glossitis, leaf-ready tongue, or neurological manifestation, other uncommon symptoms may be mild jaundice, angular stomatitis, purpura, melanin pigmentation, symptoms of malabsorption, weight loss, and anorexia. How you can diagnose megaloblastic anemia in lab? Laboratory investigation or findings of in a suspected case of megaloblastic anemia, they are aimed at two aspects. Number one, general laboratory investigations of anemia, means which include hemoglobin, blood picture, red cell indices, bone marrow finding, and biochemical tests. Then second group of investigation could be a special test, which are to establish the cause of megaloblastic anemia, as to know whether there is a deficiency of vitamin B12 or folate or both. So general laboratory finding or general investigations are Number one, blood picture and red cell indices. So, estimation of hemoglobin, examination of blood film, and evaluation of absolute value, they are essential preliminary investigations. Hemoglobin estimation, most important. This can be done by various methods. Most appropriate method is SynMath method. And second is red cell. Red blood cell morphology in a blood film shows the characteristic macrocytosis. However, macrocytosis can also be seen in several other disorders, for example, hemolysis, liver disease, chronic alcoholism, hypothyroidism, aplastic anemia, myeloproliferative disorders, and reticulocytosis. In addition to the macrocytosis, blood smear, they demonstrate marked variation in the size of the cell, that is anicocytosis, variation in the shape of the cell, poikilocytosis, and presence of macrovelocites. Basophilic stippling and occasional normoblast may also be seen. Reticulocyte count. Reticulocyte count is usually low to normal in untreated cases, but if patient is on treatment, then as early as in 3 to 4 days, if patient is responding to the treatment, there will be an increase in the reticulocyte count. Absolute values. The red cell indices, they show an elevated MCV. This is above 120 femtoliter. Leukocytes, in case of megaloblastic anemia, you will find hypersegmented neutrophils. Means a neutrophil having more than 5 lobes. So this is the earliest sign of megaloblastic anemia, in which you will find more than 5% of the cell in the blood film show, if seen in the blood film, they raise the suspicion of megaloblastic anemia. Platelet count may be a normal or only moderately reduced. In the blood picture, you will see that there is a macrocytic red cell. In marrow, you will find that typical megaloblasts, they are found, and marrow iron stores, they are either normal or they are increased. Bone marrow finding. The bone marrow examination is very helpful in the diagnosis of megaloblastic anemia. As I told you earlier, in iron deficiency anemia, usually bone marrow examination is not required, but many a time to diagnose or to confirm the megaloblastic anemia, bone marrow examination plays very important role. What did you find in marrow? There is a marrow cellularity. Marrow is usually hypercellular with decreased myeloid erythroid ratio. What happens to erythropoiesis? There is a erythroid hyperplasia due to characteristic megaloblastic erythropoiesis. Megaloblasts are abnormal, large nucleated erythroid precursor having nuclear cytoplasmic asynchrony. That means the nuclei are less mature than the development of the cytoplasm. Nuclei are large, having fine sieve-like and open chromatin which take a light stain, while the hemoglobinization of the cytoplasm is normal or at a faster rate. So nuclear maturation is lag behind that of the cytoplasm. So this is just reverse in compared to the iron deficiency anemia, in which cytoplasmic maturation lags behind. What will you find in a peripheral smear? You will find hypersegmented neutrophil, Howell-Jolly bodies, that is intracellular remnants of granules, basophilic stippling. You may find Cabot ring and macrocytosis. While in the bone marrow picture, you will find megaloblasts, which are very typical, that a large rounded oval nucleus with sieve-like chromatin pattern, open chromatin. What are the biochemical findings in a case of megaloblastic anemia? Biochemical abnormalities are observed in cases of megaloblastic anemia. Number one, there is rise in serum unconjugated bilirubin and LDH. This increase in unconjugated bilirubin and LDH is because of ineffective erythropoiesis that causes marrow cell breakdown. So because of the marrow cell breakdown, you will find increase in unconjugated bilirubin and increase in the serum LDH level. Unlike iron deficiency anemia, here serum iron and ferritin, either they are normal or they are elevated. What are the special tests for cause of specific deficiency in evaluating a patient megaloblastic anemia? It is important to determine the specific vitamin deficiency, which can be done by assay of vitamin B12 and folate. In sophisticated clinical laboratory, currently automated multi-parametric random access analyzers are used. They are employed based on separation technique by chemiluminescence and enzyme-linked fluorescence detection systems, which has largely replaced the traditional microbiological assay for vitamin B12 and folate. In the old days, for vitamin B12 and folate, there used to be a microbiological assay. Now this is replaced by the sophisticated assay of vitamin B12 and folate by multi-parametric random access analyzers. The normal range for vitamin B12 in serum is 280 to 1000 picogram per ml. Value less than this indicate that there is a clinically deficient vitamin B12 deficiency. Traditional tests which were employed to establish the vitamin B12 deficiency are serum vitamin B12 assay, Sealing test, which is 24-hour urinary excretion test, and serum enzyme levels. So traditionally, what we were doing for vitamin B12 and serum folate assay, that this is microbiological assay or sealing test, urinary excretion test, or serum enzyme levels. But nowadays, the chemiluminescence method by multi-parametric analyzer, you can directly detect. How will you treat a case of megaloblastic anemia? So principles of treatment are, then in most of the cases of megaloblastic anemia, they need therapy with appropriate vitamin. So as you know, that in megaloblastic, vitamin B12 is stored in the body for 2 to 4 years, by folate is stored for 3 to 4 months. And if they are diagnosed in an early stage, then the symptoms disappear very soon, in 3 to 4 days only. But if the treatment is done late, then central nervous system involvement leads to the irreversible stage. What we give is hydroxycobalamin is given as an intramuscular injection, 1000 milligram for 3 weeks, and oral folic acid 5 milligram tablet daily for 4 months. So severely anemic patients in whom a definitive deficiency of either vitamin which cannot be established with certainty, then we have to give both vitamins concurrently. Blood transfusion should be avoided because it may cause circulatory overload. However, in severe cases, you can give packed cells very slowly, and treatment of megaloblastic anemia is quite gratifying. So as I told you that if it is diagnosed in an early stage, then it responds very well. But if there is a subacute combined degeneration of the spinal cord, then treatment is not very effective. Thank you. Sono, sono, sono.